I'm Vince. I'm one of the PGY1s. I will be doing a visual diagnosis lecture on lower extremity ortho injuries. This is going to be somewhat interactive, I hope, so participation is much appreciated. How do I go to the next slide? There we go. All right, so shout out to the visual diagnosis team for helping me through all this. I have no conflicts of interest or financial disclosures, but I can give my Venmo if anyone wants a tip. So we're going to review ortho terminology and then do some cases involving the lower extremities. So first things first, ortho terminology. What do you say when you call your consultants? Always start off with bro. Just kidding. Not really. So you always want to start off with location, right? So where in the bone is the injury? Is it proximal, middle, distal 1/3? And does it involve the joint? So is it intra-articular or is it extra-articular? There are multiple types. Sorry, the font is a little small, but some of the big points you want to make sure of is it open injury? Is it closed? Does it need emergent antibiotics? Right? Is it displaced? Is it separated? Is there any shortening in the bone? Is there angulation? In order to really fully assess all of this, you want to try and get multiple views. So if you're like me and watching a Super Bowl, right, this is me looking at multiple views. All right, so first we're going to start off with location, but in pediatric fractures. So if anyone could shout out what a type 1 Salter-Harris would show. Close. So it would be separation, but it would be straight across the growth plate. This is kind of a read my mind, but what would be a type 2? Yep. 3. Oh, sorry. And then 4. Yep. And 5. Yep, exactly. All right. So now we're going to start with some cases. All right, so you got an 84-year-old woman brought in by EMS after she fell off her grandson's Peloton. Exam, externally rotated and shortened right lower extremity. Someone describe what they see on the x-ray. Which side? Yeah, so there's a very special arrow sign, right? So this is a non-displaced femoral neck fracture. So here is a diagram. Most importantly, we want to know if we're up to the trochanter. If it is after the trochanter or involves the trochanter, it's an extracapsular fracture. If it's before that or proximal to that, it is an intracapsular fracture, right? Here are also different delineations. So intracapsular versus extracapsular are the big categories. This one, any guess on what that is? This is also intracapsular. It is transcervical. There's also a little dermoid cyst right there, those little teeth. All right, so the next one, any guesses? Remember, this is an ortho lecture, not urologic. So this is going to be a left-sided intracapsular. Yeah. So this is zoomed in. Oh, it might be a little bit difficult to see. There's like a fine little line right. Oh, wait, hold on. Right there. And then this is near impossible to see, but there's like a little cortical defect right at the edge there on the lateral view. So what kind of complications do we worry about for femoral neck fractures? Yeah. So there's actually, along with avascular necrosis, with repair of these, there's actually a very high morbidity and mortality. There's a 2002 study that showed the 30-day mortality for serious cardiac and pulmonary complications was 22% and 17% respectively. At 1 year, that jumps up to 36 and 44%. in general, if the fracture is open or if there's neurovascular compromise, we always want to consult our consultants, so orthopedics. Here's the next one. 52-year-old man, history of scurvy, right below knee amputation, comes in for right knee pain. Status was jumping approximately 10 feet off an enemy ship into his getaway boat. Exam shows an effusion, diffuse tenderness palpation overlying the right knee, and inability to bear weight. These are his films. Any guesses? Where? So here's the amazing arrow signs. And yeah, so it is a tibial plateau, but there is a grading system to this. All right, so there's types 1 through 6. So the reason why there's a grading system is because these types of fractures typically occur with axial load, so falling from significant height. And they can be pretty unstable. And so this is so the one on the left is the original picture. And then the one on the right is normal. It might be a little bit difficult to see. And then this is the oblique view, even though they're different legs. One abnormality that you can see also is called a lipohemoarthrosis. Typically, this occurs with an intra-articular fracture, such as a tibial plateau fracture, because there's an escape of fat and blood from the bone marrow into the joint. If you have a very high clinical suspicion for a tibial plateau fracture, you want to grab like a CT or an MRI. As a result, vascular compromise can occur from large effusions. So what do you guys think is the most common short-term complication of tibial plateau fractures? You probably want to consult ortho if you see this. So if there's a very large effusion, it can actually cause compartment syndrome. And that's actually the most common short-term complication. So you definitely want to get orthopedics on board early and pretty much as soon as possible, especially if you see this sign. If there's a lateral plateau fracture, the ACL and MCL can also be injured. And if there's medial plateau, then PCL and LCL. Otherwise, if there's no neurovascular compromise, you can actually send these patients home with a knee immobilizer and have them follow up with ortho in 2 to 7 days. Okay.
For tibial plateau, one of the times you're not going to see it on the X-ray, so you have to have a high clinical suspicion because you should expect patients to get a CAT scan because you really don't know that this patient has tibial plateau. It's different between somebody who's having a sprained knee and somebody who's almost definitely need operative repair at some point. And whether or not I had a patient ask me, we just had pain with the tibial plateau and the X-ray and show it.
All the fractures need actually CTs also, because if it's suppressed more than, I want to say 3 or 5 millimeters, then they need to get it raised and need hardware to bring it up.
Gotcha. All right. So the next case is a 27-year-old woman. She has right ankle pain and swelling after she had her bike fall on it while she was making a sharp turn. Couldn't ambulate, but she's got diffuse tenderness palpation at the right ankle with significant edema circumferentially. So what decision-making tool would you use to aid in figuring out whether or not to image? Yep, so you whip out MD Calc and you pull up the screen. And so these are all the areas that if they were tender, you would say, and they can't bear weight both immediately after and in the ED, let's get an image. So here are your pictures. What do you guys see? Any guess? Yeah. Yeah, so this is a bimal, okay? There is also a classification system for this. So this involves both the medial and lateral malleolus. There's no involvement of the posterior malleolus. So the classification system is Weber A, B, and C. There are multiple classification systems. This is just one of the most popular. So this is mainly based on this view is the Mortise view. So the big thing we want to focus on here is the joint spaces and whether or not they're wide. So this is called the plafond, and this is the talar dome. And there's all these ligaments here. So there's two ways to classify this. So one of them is the joint space, which is indicative of ligamentous injury. And the second thing involved in the classification is where the fibular fracture is. So if it is at the level of the plafond or below, then we consider that a Weber type A. If it's at the plafond or a little bit above, then that's B. And if it's way above the plafond, then that is Weber type C. So based on the arrow signs, what do we think this is? Any guesses? Anyone? All right, so it's a trick question. It's a trimal. Technically, this would be a Weber type A though, because the fibular fracture is right there. A to a B maybe. Okay. So another case, 13-year-old boy. He was trying to do a TikTok dance. Twisted his ankle. He's got right lateral mal tendinous palpation with associated edema and inability to bear weight. Here's your films. What do we see? Yep. So because he is a PEDS patient, we have to consider the possibility of this being a Salter-Harris. So which type would this be? 1 through 5. So there's the arrow sign. This is actually a type 3. So there's the chart. This is also known as a Talot fracture. So this involves the anterior lateral portion, mainly because it takes the longest to mature. This is just another view. And then it is near impossible to see, so I enhanced it here. This is just impossible to see. Yeah. So this is why you get multiple views, right? To confirm it. And so the distal tibial growth plate takes about 18 months to close, and it always closes in like the same pattern. So it goes from central to anterior medial, posterior medial, and then finally lateral. But if it takes the lateral edge the longest to close, and you have an injury involving like a twisting injury, then the AITFL will actually just pull the anterior lateral portion of the tibia and essentially avulse it. And so this is how the growth plate actually closes. And this is why Talot fractures occur the way they do. In conclusion, always get multiple views, try to be systematic. And if not neurovascular intact, just call your local ortho bro. And this is just a nice little meme. All right, that is it.